Welcome to Bedside Case Files, where we explore real patients, real findings, and the art of diagnostic reasoning, right at the bedside. This is episode 3, The Yellow Woman. This 48-year-old woman presents with fatigue and confusion. What do you notice about her? In this single photo, there are at least 3 physical findings to observe. First, the most striking finding. She's yellow, both her skin and even more dramatically her conjunctiva. She's jaundiced and has scleral icterus. The 3 primary colors are red, yellow, and blue. Diseases can make skin color shift toward one of the primary colors. This patient's yellow hue tells us something about her. By the way, the eyes are an excellent place to look for icterus in patients with darker skin tone. This photo also reveals hollow temples, indicating temporal muscle wasting, a sequelae of malnutrition. Finally, there are red skin lesions about her chest. What are these lesions? Let's take a closer look. Here's a close-up video taken of the same lesion in a different patient. Spider angiomas are a form of telangiectasia and are so named because, well, they resemble a spider. The central arteriole looks like the body of the spider, and the radiating branches look like spider legs. Spider angiomas do something unique. When you blanch a spider, it fills from the inside out. The findings we've seen so far should have already generated a hypothesis about the underlying condition this patient might have. And our hypothesis leads us to her hands. What do you notice about her fingernails? She's lost her lunula and instead has a ground glass appearance to her nails except for a thin strip of brownish pink coloring at the distal end. Together, these features are known as Terry's nails. You turn her hands over and see this finding. Palmar erythema describes redness in the thenar and hypothenar areas and the base and pads of the fingers, with sparing of the actual palm area, so it's a bit of a misnomer. Remember the confusion the patient presented with? Based on our findings so far, and your leading hypothesis about her underlying condition, what do you think is causing the confusion? Let's perform an exam maneuver. We ask our patient to hold her hands out like she's stopping traffic, but she can't seem to keep her wrists flexed. There's an intermittent loss of flexion in the wrist resulting in a flap. By the way, if you look closely, asterixis is not the only clue to be gleaned from this video. What else do you see? Notice her pinky finger? She's got Dupuytren's contracture. Is that associated with anything? Also look at her forearms. She has several ecchymoses, perhaps another clue to her underlying condition. We examine our patient's abdomen next. It's symmetrically distended and we perform a specific exam maneuver. To panic, dull. Let's have you roll this way. To panic again, so that's shifting dullness. The presence of shifting dullness tells us our patient has ascites. Let's briefly review ascites using this framework brought to us by the textbook Frameworks for Internal Medicine. As the framework shows, the 2 mechanisms of acidic fluid formation include portal hypertension and non-portal hypertension. Do you remember how we determine this? The serum ascites albumin gradient, or SAG. In our case, we perform a paracentesis and the SAG is determined to be greater than 1.1, indicating that the ascites is a result of portal hypertension, the causes of which further subdivide in relation to the liver: prehepatic causes, intrahepatic causes, and posthepatic causes. Do you see an entity in the framework that could explain not only the ascites, but all of the physical findings we've observed so far? Let's review our findings. We have jaundice, temporal muscle wasting, and spider angiomas, along with Terry's nails, palmar erythema, as well as asterixis, Dupuytren's contracture, and ecchymoses. Our patient has cirrhosis. Cirrhosis represents the end stage of many chronic liver diseases, a process of fibrosis and nodular regeneration that distorts hepatic architecture and impairs function. The exam findings we saw tell that story at the bedside. Jaundice and scleral icterus reflect the liver's failure to conjugate and excrete bilirubin. Temporal muscle wasting signals catabolic metabolism and malnutrition, both hallmarks of chronic liver disease. Spider angiomas and palmar erythema result from excess estrogen and vasodilatory factors normally cleared by the liver. Terry's nails, with their white proximal nail beds and distal brown bands, occur from hypoalbuminemia and vascular changes in the nail bed. Dupuytren's contracture can arise from fibroblast proliferation in response to altered metabolism, often seen in alcoholic cirrhosis. Ecchymoses stem from coagulopathy and thrombocytopenia, the liver's inability to synthesize clotting factors, and the splenic sequestration that accompanies portal hypertension. And finally, shifting dullness reveals ascites, the physical manifestation of portal hypertension, leading to fluid transudation into the peritoneal cavity. Together, these clues form a cohesive narrative: the failing liver, not seen in lab values, but on the skin, the hands, the eyes, and the abdomen. This is the essence of bedside diagnosis, recognizing how physiology and pathology reveal themselves through careful observation. I hope you enjoyed today's case. I'm Andre Mansour, and this is Bedside Case Files.